better, expanding access and applicability of automated insulin delivery systems, followed by panel discussion. To chair the session, I would like to invite our chairpersons, Dr. Asha Ashik, Center Head, Consultant Diabetologist, Jothydev Diabetes Hospital, Kochi, and Dr. Balagopal PG, Director, Cochin Cancer Research Center.
On automated insulin delivery system, which is very relevant in contemporary diabetes practice. The speaker is Professor Tadej Battelino from Slovenia. The panelists include Dr. Kesavadev, Banshi Saboo, and Dr. Julia Meder.
So, it's a AID panel discussion, and to head the panel discussion, we have with us none other than Dr. Tadej Battelino from Slovenia, and he needs no introduction to this audience. The man behind TIR, the chief organizer of ATTD, past president ISPAT. Over to you, sir. And
our panelists include Dr. Kesavadev. Dr. Jothydev is an internationally acclaimed diabetologist, and it is a mere waste of time to introduce him. Dr. Jothydev started his career as a lecturer in the Department of Medicine at Government Medical College, Trivandrum. Later, he started his own clinic, and he is the first person in the state to introduce the automated insulin delivery system, and he is the first clinician in the state to introduce the telemedicine, when telemedicine was not available in any of the major hospitals or major corporate hospitals in the state. He is the organizing chairperson of National RSSDI 2025, National President of Diabetes Technology Trust of India, Managing Trustee P. Kesavadev Trust. He has more than 200 publications to his credit, both in national and international journals, and is a pioneer in cost-effective treatment of diabetes with the use of telemedicine and technology, which was widely appreciated in the recently concluded international conference in Chicago. Our second speaker is Julia Meder. She is a professor of diabetes technology at Medical University of Graz. He is a visiting professor of University Hospital of Bern, Switzerland. She has more than 190 publications and she is a recipient of multiple national and international awards. She is executive board member of EASD and chairperson EASD Training and Education Committee. Dr. Banshi Saboo is a chief diabetologist and chairman, Diabetic Care and Hormone Clinic, Ahmedabad. He is the global council member of EASD, chair IDF Southeast Asia, secretary Diabetes India and India Academy of Diabetes, member advisory group American Diabetic Association, past president RSSDI and AIIRO. He is a recipient of P. Kesavadev Trust Award for Diabetes Education Awareness in the year 2025. Over to you. Over to you, Dr. Tadej Battelino.
Hello, everybody. So thank you very much again to Jothydev for the kind invitation. It's a real pleasure to be here with you in your beautiful country. I would like to share a little bit with you how I see AID and why I believe it's important. Those are my disclosures for you to review. And what I thought perhaps is where we are at the moment with AID globally, and then possible improvements. So how do we look in the near future? Perhaps we will even touch what's a cure for type 1 diabetes. I think the most important data comes from the United States DirectNet. This is the latest publication from a month ago, and what they showed is that children with type 1 diabetes have brain damage. Brain damage, this is a longitudinal study, starts with 6 years, it goes all the way to 12 years. As you can see, there is a significant difference here in the white matter brain damage in between the control group in blue and the people with diabetes, children with diabetes in red. And what's really important is that all this is related only to high glucose, not to hypoglycemia. Zero effect of low glucose. It is only related to high glucose. Here, either time above 250, either time in range, and zero, please note, zero association with low glucose. So this is very important. And if you look, it starts with an A1C above 6% already. So it's very, very serious. This is the latest data. They have at least 5 papers before this one showing the same. And same is true for cognitive impairment. So cognitive impairment correlates nicely. Those are the IQ tests with the brain damage. We asked ourselves whether acute hyperglycemia is also dangerous. So we put kids with type 1 diabetes inside the functional MRI, and we clamped them. We used clamp, euglycemic clamp, from euglycemia to hyperglycemia. And look what's happening. Immediately with high glucose, the spatial working memory declines, acutely declines. So we thought this was important. And then we saw DirectNet did this randomized controlled trial. And they randomized people on closed loop or regular. And after 6 months, please look, that outcome time in range was very, very modest, 57% only. Yet, there was a clear improvement in cortical surface area, regional gray volumes, functional anisotropy, perceptual reasoning IQ score, as well as functional brain activity. Only 6 months of closed loop basically brought these benefits to this randomized controlled trial. And then, of course, the question is, how's about long-term effects on the brain? This is DCCT data, EDIC data. As you can see, a profound impairment of the brain, both structural and the function. So elevated glucose is harmful. This is really important to understand, even a little bit elevated, and I will speak more about this in the afternoon. Do we have data for very small? And we do. This is the latest publication. I think it's now a month ago in Lancet DE. This is preschool children, 2 to 6 years. There was an obvious superiority for both time in range and A1C in the study. But what's important is this is the time in range. As you can see, they reached 68% of time in range, and an A1C dropped down to 7 in only 6 months. But then there was no insulin increase. And importantly, there was, of course, a redistribution between basal and bolus, and there was no weight increase, because people are feared that automated insulin delivery will increase weight. Well, it doesn't. It depends on what you eat, of course. And this is the outcome. And please notice that most of the improvement was in tight range. Tight range is 70 to 140, so normal glycemia. And this is really important because, as you can see here, this is the outcome, but then this is above the tight range, is the same in manual and automated. Whereas this tight range, the normal glycemia, this is where the difference is of 11%, so the very, very clear improvement. If you look other data, so this is control IQ, the time in range, this here is only 64%, so not all algorithms actually perform the same. And this study is first in human, very recent publication of full closed loop. People want full closed loop because hybrid, you still need boluses for meals. So how's about full closed loop? Well, it is not the same. Please note that the time in range, actually, it only reaches 55%. So it's not the same. So if you want a good outcome for people with type 1, at the moment, you still need to use the hybrid way. So you have to announce meals. And here is the variability, which remains super high. In type 1, 37, as you can see, super high. A little bit better in type 2 diabetes. And importantly, in type 2 diabetes, the weight goes up. So full closed loop, of course, then you eat whatever, the system gives you insulin, and the weight went up from 36 BMI all the way to 39. Same, another study, another way to look at it is a meta-analysis. This is a systematic review and meta-analysis of full automated delivery. And again, the time in range, even with the dual hormone, actually, it is not significantly better. This is a very important message. We used to discuss this for decades, actually. And then finally, as you can see, hybrid ID actually does better. And even, of course, when you announce meals, it is better. But a fully closed loop in any way doesn't do the same as a hybrid at the moment. So hybrid closed loop remains superior. Importantly, the time below range, which was typically something that dual systems were famous for, please note here that actually it is not the case. So dual hormone full closed loop has a higher time below range than the hybrid. How's about disparities? I think the most beautiful thing of AID is that it diminishes disparities. Why is that? Because automated systems, artificial intelligence doesn't understand poverty, doesn't understand social status, doesn't understand education, doesn't understand the color, the skin, doesn't understand religion. It only understands glucose. So it basically works similar for everybody. We tested this. This is the well-known data from Australia that shows continuous disparities when you use MDI. We made this study in a large cohort of 9,000 preschool children around the world. Just to let you know, so this is Germany. Oh, sorry, this is a very quick thing. This is Germany. This here is Czech Republic. This is Austria, where Julia comes from. This is Switzerland. This is, of course, Italy. And this tiny spot here is Slovenia. It only has 2 million inhabitants, so like a small village in India, plus minus. Also, New Zealand took part, and this is Colorado from the United States. And here, please note, the only system used that made zero difference, zero disparities, was an AID. And this is a really important message. So the disparities disappears when you use an AID. Another study is in between white and black in the United States. And please note that disparities were significantly diminished where an AID system was used. Not completely abolished. It still depends on your social background, but very, very diminished. So, of course, behavioral differences remain important. How much you wear it, how much you use automation, all these things were different in between the white and the black cohort in this study. We also showed in another way, if you want, this is a recent publication from Diabetes Care that we did together with Italians. The time in tight range, if you want a very high time in tight range, you need to reduce carbs. I know this is very difficult in India, but carbs are not a good idea, actually. Here we just showed on the amount of carbs reported, the lower your carb intake, the better actually is your time in tight range. If you want to focus on adults, this is the recent type 1 exchange registry here in red and in blue from the United States. As you can see, there is an improvement. But this is USA, this is Europe, and this is what 100,000 users from 780G, so from the Medtronic system does. As you can see here, in this age group, 7% of A1C. In older population above 55, it's even below. It's around 6.8 A1C. So extremely good outcomes. And please note, there is no difference during the puberty, which of course is very welcome. Many studies show the same. So this is again a recent study from DTT, adult people from England. As you can see here, I mean, British still focus on hypoglycemia. British, as you know, do not have the best system in the world, not even by a margin, but they try very hard now, so they can reach now a 60% of time in range. This is approximately 12% below us. We usually have an average of 72%. And here is actually, you can see it's still a hypo-focused management, which is wrong. They have zero hypoglycemia, but then the time in range remains lower than the Europe. This is what they use. As you can see, a vast majority, 47%, use Medtronic 780. How's about type 2 diabetes? Well, in insulinopenic type 2, we have the same data. You can also use a hybrid closed loop, and you use it very successfully, actually. And many, many people probably in India could benefit from this. Same is true for pregnancy. I will just give you a open source data for those that like open source because, of course, it's free. Here you can see very, very high time in range. So this is time in range pregnancy, 63 to 140. As you can see here, actually, a very high time in range for loopers as compared to the different available algorithms. First trimester, second trimester, as well as the third trimester. So also an important option for pregnancy. This is loop, and loop is the best results. I would like to introduce a little bit time in tight range for you. Time in tight range is inside the time in range 70 to 140 and designates normal glycemia. And here you see that with 780G, you can actually easily reach a time in tight range above 50%. And this is a very important message, without the concomitant increase in hypoglycemia. So a very fortunate algorithm. It allows you, with optimal settings, that you go very high. Here is the Italian study. Look, they reached time in tight range of 60%, extremely high, but hypoglycemia remains below 3%. So a very important outcome. This is the Italian study group, and without an increase in low. This was also true in the 13,050 analysis that we did together. And you see here, importantly, that with optimal settings, so time in tight range of 50% is achieved by 44% if you use the regular setting, but by 80% if you use optimal settings. So you can set 780G so that 80% of your people will have a time in tight range above 50%. Time in tight range is a new philosophy. The Swedish people, they are the most advanced, only use time in tight range. And please note what they say, it's comprehensive, meaningful, and manageable. And this is their population. More than 50% of all their children have a time in tight range of 55. This is the outcomes. And last question, what is a cure? Well, you can perhaps add to cell therapy automated insulin delivery. Here are the outcomes. As you can see, you easily achieve time and tight range of 90%. And here, you can use automated insulin delivery with faster S parts. We did a study here and clearly showed the time in tight range postprandially is better the faster the insulin that you use. And excursions and the peak all lower, including the area under the curve. These differences are visible only if you look at the tight range. So this is a really important message. The next step may be human-machine co-adaptation. This is a randomized controlled trial with a digital twin. A very important thing. I know you have several digital twins in India, and this perhaps may become best friends to many, many people. Here is this randomized controlled trial by the Boris Kovachev group from University of Virginia. Please note, either in the end or in the beginning, they were randomized, a huge improvement in the outcome. So digital twin may be a very important new thing on the block. So are the neural networks. So neural networks are the new way of presenting closed-loop insulin delivery. The first one is already FDA approved. So we have a very interesting future in front of us. What's a cure? Cure is an insulin independence. So independence of work. Even if a system, a computer, or a cell therapy, or a combination of it is giving it to you, and whichever way we achieve it, many, many people will be happy. Allow me a couple of conclusions. So number one, glucose is dangerous. Even a little bit elevated glucose is dangerous. AID is not a cure, but it's extremely helpful. And maybe even given in combinations, in co-therapy, particularly with GLP-1s now recently, with more artificial intelligence, perhaps with cell therapies. And we have to collaborate with everything to reach the cure. You're warmly invited to ATTD Asia. It's becoming a big meeting. It will be in December 9 to 11 in Singapore. A lot of new things, a lot of new technology, and new way to use GLP-1s and other dual, triple, and other medications will be presented. And of course, the ATTD in Europe, in Barcelona, next year. With this, I thank you very much for your attention. This is my team. They have to work while I talk to you. Thank you.
So now we have a discussion on various clinical scenario in diabetes practice. The panelists are Dr. Jothydev, Kesavadev, Banshi, Saboo, and Dr. Julia Meder. The topics include management and diagnosis of type 1, type 2 diabetes, management of diabetes during pregnancy, pancreatogenic diabetes, and management of diabetes during the holy month of Ramadan. My pleasure to invite Dr. Jothydev to speak on pancreatogenic diabetes. Over to you, Dr. Jothydev.
Thank you. Dr. Balagopal and Asha Balagopal is my classmate and he is currently the director of Cochin Cancer Center. Thank you very much, respected chairpersons. And we are delighted and it is so fortunate for us to have two foreign speakers, two international thought leaders, Dr. Tadej Battelino and Julia Meder. And it is a privilege for me to speak after Dr. Tadej Battelino. And this discussion is on the use of automated insulin delivery devices, advanced hybrid closed-loop systems in a rare disorder, but not that uncommon in south of India, and that is fibrocalculous pancreatic diabetes, which results from fibrosis and calcification of pancreas. And most of us will have one or two patients in our practice, and many a time it goes undiagnosed. And this is how you confirm the diagnosis with a X-ray or a CT scan, and this disorder can be missed in the conventional ultrasound scan. And this is the story of, I would call it a sweet journey for more than 17 years with fibrocalculous pancreatic diabetes and insulin pump therapy. And she met me first in the year 2008, and at that time she was 39 years old with the following glucose levels. So you can see the fasting, the postprandials are elevated, and with multiple episodes of hypoglycemia, recurrent episodes of hospitalizations despite a near normal hemoglobin A1C, which is also described in pancreatogenic diabetes. And she was on a premix insulin, and we shifted to a basal bolus regimen, and within a month the family opted for insulin pump therapy. I always used to say the best technology for diabetes is the technology which is available at the moment of time. And in 2008, this was the first, which is the best technology, the Paradigm 722. And this is how the CGM looked like. And in 2016, for the same patient, we switched over to 640G. And then recently, in 2023, we started her on the advanced hybrid closed-loop system, and that is 780G. See the remarkable improvement. And this is definitely a path-breaking innovation. And this is how the average glucoses have behaved with the three therapies, and a phenomenal reduction in the hemoglobin A1C. And this is a snapshot from our DTMS electronic medical records. And this is the symbolic representation of time in range as coined by Dr. Tadej Battelino. The person sitting here is the scientist who coined the term time in range, which is replacing the hemoglobin A1C. And for any therapy, including continuous glucose monitoring devices or with the conventional insulin pumps, it is not possible. It is impossible to reach a TAR more than 70%. And this has been accomplished. And this dream has been accomplished in this lady, more than 78% time in range. And this is a recent stat. She is currently 55 years old. And FCPD, the duration is 26 years. And in India, in Kerala, we began insulin pump therapy in 2004. And this is a very popular picture which appeared in the front page of the most popular newspaper back in 2005. And this person is very familiar to most of you sitting here. He is a doctor. And at that time, he was a minister. And this is Dr. M.K. Munir. And according to him, when there is a life-saving innovation available for a disease, he's a modern medicine doctor. This is what he said: "It is my responsibility as a politician and a doctor to go public." And he announced this in public in almost all the media in 2005, and the pumps became very, very popular. We are extremely indebted to two people, two researchers who in the first 10 years of insulin pump therapy in the country, Dr. Satish Garg and the same Tadej Battelino, who visited multiple times to organize workshops across the country for doctors. And I also, along with our friends, used to travel with them. And this is a recent picture. In 2022, a young girl on 780G, and this is the automated insulin delivery, the only device available in our country which automates the delivery of insulin, changes basal once in every 5 minutes, and once it has reached the maximum basal, it will automate even delivery of a bolus. And the family is happy, the parents are happy, the public, the teachers are happy, the children are celebrating, and these are some of the publications, the real world evidence from our country. And this is from our clinic, the first 25 patients. And look at the time and range. And this is something which was thought to be impossible in type 1 diabetes. Because doctors like me, Dr. Banshi, myself, we used to learn from the ATTD. And ATTD is founded by Dr. Tadej Battelino, who is sitting here. EAST, a very prominent EAST council member, Julia Mehta. So we are learning technologies from them. And throughout the last 18 years of ATTD, the technologies have advanced a lot. And this is for the first time ever since the modern medicine have innovated all these technologies. The TIR has reached a number of more than 80%. No wonder Medtronic has been very successful for the first time. They were there in India for more than 2 decades. And in 2024, they crossed more than 1,500 780Gs in our country. So in conclusion, though I spoke about pancreatogenic diabetes, Dr. Banshi will be speaking on other types of diabetes and the use of 780G. This is a take-home message. Of course, for doctors like you and me, we take care of people from different communities across the state, and many of them are unaffordable. They cannot procure such expensive devices, but for every person who really deserves it, and especially as a life-saving device, it is our responsibility. We should be brave enough. We should be brave enough in initiating a conversation of life-saving devices, whether they buy it or not, that is immaterial, but they may procure it. They may find a way to procure it. And we should be brave enough to discuss those life-saving innovations with our subjects. Thank you. Thank you, dear friends.
I invite Banshi sir to talk on AIDs in type 2 diabetes and Ramadan.
So one mic you can give to Julia, so in between I will be asking her questions, and that's what the panel discussion. I'm sure everyone is convinced that for type 1 diabetes, AID is the best. There is no doubt about it as far as the time in range is concerned, to have a better quality of life with low incidence of hypoglycemia, nothing to discuss. But there are few conditions like type 2 diabetes. Already Jyoti had shown for pancreatogenic diabetes or FCPD, or during Ramadan, or a person with type 1 diabetes, even at the time of onset of diabetes, should we use AID? And that's what the panel discussion. So we would like you to have your comment also and your question. This is what the time in range, Dr. Battelino in 2019, and I was part of it, the time in range, whether anyone type 1 or type 2, should have more than 70% of the time in range. And this is what, if they are using continuous glucose monitoring. And this is very important for all type 2 diabetes. And we know that many of our type 2 diabetic patients are not controlled, even after them starting on a basal insulin. And this is fact. We know that even we start them on a basal insulin to initiate. We give them sometimes GLP-1, intensify them. But few type 2 diabetes patients, they are on basal bolus therapy. They are like we are treating them as a long-standing type 2 diabetes patient, as a type 1 diabetes. They are on basal bolus therapy. Their sugar is still not controlled. And some such intensified regime which we are using, putting them on a continuous glucose monitoring, all those things, but still it is very difficult to get them in time in range. So I will show one data, and then I will ask the Julia that what is her personal experience. We had in India using even in type 2 diabetes patients also the insulin pump AID, We will show our own data, and we are again further collecting few more patients' data, and which we will be publishing. This is one Omnipod 5 results, secure type 2 diabetes pivotal study, to show that the people who are put on AID, type 2 diabetes, long-standing on basal bolus therapy, significantly improved. This is a impact 2 study, in-home study, Minimate 780Z in type 2 diabetic patients, and there is a significant improvement in time in tight range, and that is what their A1C improvement, time in tight range improvement, time in range is improvement. This is, they have reduced the overall diabetes burden. That is what they have to take. The bolus, which was 38.1, which is decreased to 30.9, and 13.4 units they were taking automated. This is our data from India, type 2 diabetes, 21 patients who have used with a mean sensor glucose was 143, and you can see here a very significant difference in A1C, which was there in 9.1, which had come to 6.9, and the important thing is they improved from the time in range from 65.2 to 71, and no increasing risk of hypoglycemia. So this is something which we had shown from India also, 21. But as I told you, AID is not approved, or it's not for the type 2 diabetes, it is for definitely for type 1 diabetes in the standard of care. So now I will ask Juliana that, what is your experience of using AID in type 2 diabetes in your country? As officially it is not recommended. I am talking for long-standing type 2 diabetes who are on basal bolus. They may be on GLP-1 plus minus. They may be on other drugs also, SGLT2 and other drugs. But what is your personal experience of using AID in type 2 diabetes?
We do have a limited number of cases in type 2 diabetes in my clinic. That would be roughly 10 per system that we have. For them it is reimbursed. Interestingly, it's easier to have it reimbursed for the Ypsomed system because they were smarter in the way how they applied for reimbursement. And usually you have to fight then if you want to use another system than the one that is reimbursed. Training was easier for them on the combined system, of course, because then you have only one contact point who does the training and who's your support line. And people actually do quite well. Usually we set the younger ones with type 2 diabetes on AID, who are in active life in their professional life. What we definitely manage is to get them down with their hyperglycemia. Because what we see even in pump-treated people with type 2 or pen with a sensor, the average time in range is 55, even if they have all other oral agents on board. So AID moved that up to roughly 70-75%.
That is what we had shown here in this
you have
data
here
also.
as well. Yeah.
The similar data from India also. So in older pump, we have used for many of our patients in type 2 diabetes. I am sure Jyoti will agree that older for convenience purpose. Many of our type 2 diabetes patients who are on basal bolus, who are on multiple times insulin injections, and for convenience we had used it. At that time it was not sensor augmented pump, but AID definitely we are first pushing for all type 1 or insulin deficient. But some of our type 2 diabetes patients who are long-standing type 2 diabetes on basal bolus still not able to achieve time in range more than 70%. But I also agree with you that it is easier to convince a type 2 who is long-standing because he himself has to take the decision for taking the insulin pump. While for a type 1, it's a family, his pediatrician, other doctors and many more, they have to take the decision. So for type 2. Your Jyoti, any experience of using type 2 AID?
Yeah, we do have patients on 780G with type 2 diabetes, and as you said, the older generation insulin pumps are quite different. They are standalone insulin pumps, and when we are discussing today about AID, they are totally different from the older generation of insulin pumps, and they are just devices for continuous subcutaneous insulin infusion. But automated insulin delivery means it is connected via the sensor with an algorithm, and it is increasing the dose of insulin when there is hyperglycemia. It is reducing the dose of insulin when there is impending hyperglycemia. It is even suspending insulin when there is a profound hyperglycemia or even before the occurrence of a hyperglycemia. So that is why it is called automated insulin delivery. And there is a subset of people with type 2 diabetes who will definitely require automated insulin delivery. And this subgroup is actually less now with the advent of GLP and gliflozins, because earlier we used to have majority on insulin pumps with type 2 diabetes, but still there is an indication. So remember, there is nothing called uncontrolled diabetes in 2025. You can control any type of diabetes and just use insulins along with other and use technologies. And you should be smart enough as a doctor to integrate technologies along with the available modern therapies so that every diabetes can be controlled.
Then the next one is pregnancy, type 1. Pregnancy with type 1, definitely we have to use the AID, that's the best. But what about the who are GDM or they are first time detected during the pregnancy? Automated insulin delivery in women with pregnancy with type 1 diabetes, there's no doubt that they should be on AID system for the best control. But we had used even 780G for some of our first time detected during pregnancy. The requirement of insulin is very high. Even after putting them on a continuous glucose monitoring, we find that there are multiple fluctuations or not getting the time in range, which is like more than 85 or 90% time. They should be in time in range. And we find that a advanced hybrid closed loop system in type 1 pregnant woman is really game changer for them to achieve a tight glycemic control without getting hypoglycemia. And one of the wonderful, but still we can't use, one of the reason is the cost, they have to pay from their pocket. Even in India, the company and some of the clinics started giving them on a rental basis that you can use it only for a few months or during the uncontrolled period of time, maybe last 6 months or 3 months, and that had shown a significant improvement in control. But still, not many type 2 or pre-gestational diabetes or true gestational diabetes who are in need of AID system is not available in our country. Unless it comes on a rental basis, probably we will have a better control for these patients. So I mean, any experience of using during pregnancy AID, not for type 1, I am talking of someone who is type 2 or first time detected or early gestational, because now we see a 35-year-old female, she is known diabetes since last 5 years, or IVF patients who are going for IVF therapy, having high sugar already and using AID. Any, Juliana, any experience of using? Anyone in the audience who have any experience of using AID? The older pump which we have used, because they used to give it again for the convenience. Yes, Purvi, you have any experience of using? Yes, please. Yes, the type 1 we have. I mean, for a type 2 or a 2, because in a typical type 2 diabetes patients now, because of SGLT2 and GLP1, the requirement of insulin pump or AID will not be so high. But definitely during GDM or during pregnancy, you don't have other molecules you can't use. It's only insulin, and sometimes the requirement is very, very high. Still, it is very difficult for them to get a good control of diabetes, and there we need. So I think the discussion we can continue, so don't worry about the time, because we have the time for that. So we don't have much expense for it, but I think that's an area where around the world, if people have used AID, we can create sort of either a cases, and that we can publish also. But this is also one of the area where we can think of, unless it is available on a rental basis, because that patient may not agree to buy it for a long term. That's the only challenge for this AID system to use, particularly in India, because they have to pay from pocket, and I am sure in the insured market, they are also doing not insurance. Now the point is, should we use AID at the time of diagnosis itself, newly diagnosed patients? Will it give more benefit? That's what your Jyoti or Tade or your experience of using someone who is newly detected type 1 diabetes. I have one patient to whom I had used even at the time of diabetic ketoacidosis. We explained the patient, we started using it, but you know that after some time, as it was very tightly controlled, then patient had gone in a honeymoon phase, the requirement has gone suddenly very down, and then over a period of time, after 6 weeks or 8 weeks, actually her insulin requirement was absolutely zero. We had to ask that only now continuous glucose monitoring, no more pump. Patient had already purchased the pump, and still she is in honeymoon phase and the patient pump is lying. So I mean, should we use at the time of detection itself, or asking or explaining the patient about the AID, or we just explain the patient at that time and then later on we put her on AID system? What is your experience? What you do in your, where it is completely insured and they must be getting, but what happens to them if they go in honeymoon phase? Dr. Tadej and Dr. Juliana.
Yeah, thank you very much. The thing is, this JAMA paper is a little bit confused. As you know, this was a 2-by-2 study. There were 2 publications back to back. The other one was verapamil, and verapamil was significant. So the problem here is that the control group actually did as good as the intervention group because the study was too short. It was only 3 months. So it's very hard based on this JAMA. I'm very surprised they took it to JAMA. They shouldn't, just because the people are so famous, right? All Americans, of course. The thing is that the outcome data over 3 or 4 years just published from Stanford clearly show that the earlier you start, the better are the long-term outcomes. So I'm not saying you have to start in a day or 2, but probably within 3 months, it's a very good idea to start. So I think first thing is everybody should be on CGM, and we will discuss this in the afternoon. So there is no diabetes therapy without CGM. And this is really important. This is a really important message. And then the next step is AID. And I will tell you why. 2 things, 2 reasons. First, people don't like to measure SMBG. Number 2, nobody discusses SMBG with them unless they are in a very special center. As soon as they use CGM, they see what's happening. It's a different world, completely different world. And then, of course, if you add to this an automation system that would do most of the work on its own, it helps. So my suggestion is perhaps within 3 months, if we start an AID in a newly diagnosed type 1 person, it makes a lot of sense, and there is data to support this.
But is the C-peptide will decide? Suppose someone's C-peptide is very low at the time of diagnosis, it means in an advanced stage we diagnose, and the chances of, because this is a market where they have to buy on their own, so that the chances of going for like honeymoon phase or the patient requirement will go down suddenly, and the patient may say that, you know, why I purchased this pump, now I don't need it, or maybe for another 1 year or 2 years my requirement may not be the insulin pump. So how is it the C-peptide can be the estimation, can decide that whether they should be started at the time of newly diagnosed, or should we wait for that?
There is only one old study from Thomas Dane that showed a difference in C-peptide. That was a smaller study. So I'm not sure we can say for sure that it would preserve C-peptide. I don't think so.
Okay.
So if the question is whether we can use it after the honeymoon period, the reply is likely yes. But then only if you use CGM. Otherwise, you will not know when really the honeymoon stopped. Because I showed you, I mean, every little elevation of glucose causes brain damage. So at least in our environment, there is no time to wait. No time to wait.
Right. So AID significantly improved the outcome. This is in a patient who are secondary diabetes. These are the patient who is post-pancreatectomy, or a patient with FCPD. There is a significant improvement. As we all know that these are the patients, they behave like insulin deficiency. This is one paper which was 7-ATZ used from a real world, those who are in Ramadan. Now the first time from India also we have published one data with Manoj, myself, and some of our patients who are type 1. They could not do any fasting in last so many years, and we started using that all these 4 or 5 centers, 1, 2 patients we have tried, and this we have abstract was published in 2024 in ATTD Asia. We had used in these patients, and they could do the fasting, the Ramadan, and full 30 days Ramadan was done. They were using the insulin, automated insulin delivery system, the real world data from India, and all of them were neither they were having any hypoglycemia or hyperglycemia. So that was fine. And with this, I once again thanks JPEF, and invite all of you at ATTD Asia. The dates are 9 to 11 December 2025, and we do a dedicated meeting of diabetes in technology. This year it is in month of May in Mumbai. Dr. Manoj and Purvi, they are doing it. And with this, I thank are both the panelist and chairperson. If they want to make any final remark, Julian and Tadej, otherwise we can close the session. Thank you.
Yeah, thank you very much. I think it was a very important discussion because we see that globally we have quite the similar challenges with access, with achievement of control, and I think we are all still struggling to achieve normoglycemia in all our people, or at least avoid the hyperglycemia above 180 also in the best systems that we have.
Thank you.
So
Over
thank
to
you all
chairperson.
for the patient listening. The session is over. Unfortunately, we don't have time for question and answer session. Thank you all.